Hello, lovely friend. I am Dr. Mary Barson.
And I'm Dr. Lucy Burns.
We are doctors
and weight management and metabolic health experts.
And this is the Real Health and Weight Loss Podcast.
Hello, lovelies. We are super excited to be bringing you this series in menopause where we're interviewing guests on their expert subject regarding perimenopause, menopause, and beyond. As always, any information in this podcast is just considered general advice, and we would urge you to seek medical attention if you have any concerns about your health. If you're interested in exploring the symptoms of menopause or perimenopause, we have a checklist which you can download at our website, rlmedicine.com/checklist, or as always, you can click the link in the show notes. Thanks, lovelies. Enjoy this series. Good morning, gorgeous ones. How are you today on this beautiful Tuesday morning as this recording comes to air? Lovelies, I have the best treat for you today. I am with another expert in our menopause series. Her name is Dr. Talat Uppal. She is a gynaecologist obstetrician from Sydney, and her expertise is in heavy menstrual bleeding, a topic that we don't talk enough about because, remember, for so long, periods were always sort of secret women's business. Hush, hush, don't talk about them. Let's pretend nobody has them. And now it's time to bring it out into the open. We're going to talk. We've got so much to get through today, so I'm super excited about it. Talat, welcome to the podcast.
Thank you so much, Lucy. It's such a pleasure to be here.
You are welcome. You are like leading the charge here on educating, women, but also the general public on the concept that has been coined heavy menstrual bleeding, or HMB. And I know the medical term for this is often menorrhagia, which I think is actually quite helpful because it does give you sort of rage. But heavy menstrual bleeding is certainly a much easier term to remember and really just describes exactly what it is.
That's right, Lucy. So heavy menstrual bleeding, basically we've moved away from menorrhagia only because it's more of a quality of life issue. So we want to bring the focus to quality of life, and are women sort of leading a suboptimal quality of life because of the heavy periods that they're having?
Yeah, absolutely. As a world expert now in heavy menstrual bleeding and really leading this movement, tell me a bit about the Bleed Better and the first day and how that all works.
Thanks, Lucy. So basically, I didn't actually start out to say, look, I want to start a charity or I want to necessarily be at the forefront of advocacy for heavy menstrual bleeding. I kind of fell into it, Lucy, because I kept seeing woman after woman who was depleted, iron stores low, exhausted, tired, and it would make me reflect, like, how can we do better? How can we do better as a community? How can we do better as clinicians? And how can we better meet the core needs of the women that we look after? So I think it actually started from a bit of indignance rather than anything else. I think that was my other emotion was, hang on, this affects a quarter of women of reproductive age. That's 25%. Let that sink in. 25% of women. It's a massive number. And unfortunately, even though we've made gains in various ways, that number essentially, based on even recent online surveys, hasn't shifted much, Lucy. So really, we're still looking at between 25% and us. In some studies, up to a third of women will report that they are having heavy periods, either always or often. So I think that was where it started, from the indignance that, things that are less common, and honestly, it's not a competition. Every part of medicine or every diagnosis is important to support, but really something that affects a quarter of women should have more airtime and more funding and more recognition, and so that these women, especially because it's so fixable, in many, many instances, we can actually help move patients with their, acknowledging their preferences to better and kinder areas for them. So that was where I then did some research, and I understood that, if you want to advocate at a strategic level, you kind of are better off creating a not-for-profit so that it rests on that organization. And that was a lot of work in itself, but I'm very glad looking back that we were able to create that foundation on which we rested Bleed Better. And Lucy, the name actually was a very considered decision to bring the focus to the fact that we can improve from the baseline that we're often starting from.
Yeah.
And sometimes, Lucy, the answers are not perfect or the solutions are not perfect. But I guess the main emphasis is on, can we bleed better? Can we reduce the amount of bleeding women are losing? Can we help them with the pain? Can we just move them to a kinder space? And that's what the bigger picture feeling was around that initiative.
Yeah, I love that. And I think you're right that the outcomes focused, it's not how can we improve? So
Yes.
yeah, that's fantastic. Perfect. Beautiful. So for women who are out there going, okay, periods, heavy menstrual bleeding, what is normal? Like, I think people don't even know what normal is. So how do you help people decide what's normal?
That's such an excellent question, Lucy. So basically, I guess the first thing is that the heavy periods are more quality of life issue. So the technical definition of heavy periods is if there has been a compromise, periods that excessive loss that is affecting a woman's either physical, emotional or mental, social, and or material well-being. So we know that women with heavy periods might be curled up in bed, not able to go to school. They might not attend work or not be their best at work, best selves in terms of concentration. And also we know that, the tiredness, the fatigue, the shortness of breath for some patients, because it can result in iron deficiency and or iron deficiency anemia, which also then can have a whole layer of misery on top of the logistics of managing a heavy flow, which can be quite not a good and kind space for women. So emotionally also, with this more and more recognition that you can't divorce the psychological end of any condition really from the physical impact. And we know that women with anxiety and depression may then obviously have an escalation in that space because they're not going through something that is positive. And so I guess that's the technical definition. But what helps better understanding what a normal period is the International Federation of Gynaecology and Obstetrics, which is a global organization called FIGO, have come out to put some yardsticks and say, look, if you're bleeding more than 8 days, if you are having, a heavy flow, if you are having periods that are too frequent, more than 24 days apart, if you're bleeding, so because some women can be burning the candle on both ends, they could have a heavy flow and then last long as well. So I guess there are certain technical areas, but in terms of the questions to ask yourself are, am I using two types of protection? Am I using a tampon and a pad? Am I sort of flooding through my clothes? And that is, not normal. Am I having clots, particularly if they're bigger than 50 cent pieces? Am I bleeding for longer than 8 days? Am I waking up at night to change protection? And of course, the symptoms that I mentioned earlier, am I having any of those, exhaustion and fatigue that may be related to the heaviness of the cycles? So I think those are some clues that will tell us that, it's possible that a person has heavy menstrual bleeding.
Yeah. What's the crossover with heavy menstrual bleeding and period pain?
Yes, very good question. So about half of women who have heavy bleeding will have associated pelvic pain, whether that's pain during their periods or at other times. And if we're looking purely statistically, so 1 in 4 women have heavy menstrual bleeding, 1 in 9 women have endometriosis. And there's a version of endometriosis called adenomyosis when it's in the lining of the womb. And so there's a lot of overlap between women who have bleeding, may also have pain. But I do worry that there are lots of women that actually have bleeding and don't have pain. And that's also a cohort that we want to reach out to, because every symptom is important, and it's really important that we work with you to minimize all of them. But you may actually not have pain, and sometimes women trivialize the bleeding because they don't have pain.
Yeah, that's amazing. I think it's so interesting, isn't it? Because, I was lucky, and I say lucky, I just had no pain and no heavy bleeding. And so, but I think because people don't talk about it, and particularly the heavy bleeding, because it's embarrassing if you're staining the sheets or you bleeding, people stop wearing white pants and all of these things because they're so worried about their bleeding. And it's actually not normal.
Yes. And I think you're very right. There's so much shame and taboo still around menstrual health. And I constantly think that, why does it take so long to seek care? And truly, you've nailed it, Lucy, that one of the reasons is that women are sometimes embarrassed and they are not comfortable, or they have normalized it. I think they're such champions, they're multitaskers, they've just gotten on with it. And if I can tell you how many times I hear from my patients saying, oh, it's just 2 days, and those 2 days I don't go out. Those 2 days I work from home. Those 2 days, or it's just 3 days. It's just 1 day. So even the word just comes before the way that they describe the period. And then I'm trying to think of a tactful way of saying, but if it's a tsunami, even if it's 2 days, it's going to rob you of your quality of life. So, but the natural tendency so many times is to normalize it and to trivialize it. And that's because I think they're so resilient and so used to just getting on with it.
Yeah, absolutely. And yes, you're right. I mean, women are phenomenal, as we know. They're very stoic and, the whole childbirth and all of the things we do. But we can also, we can try and make it easier for ourselves. It doesn't have to be as hard.
Absolutely. Absolutely. And I almost think it's like a car sometimes running on empty, and they don't even at times appreciate what their baseline could be until that iron deficiency has been sorted, until that bleeding has been tractioned, and until they've had the confidence to know there's sometimes an anxiety that, am I having a cancer? Am I having a precancer? Am I having something really awful? And all of those issues have been addressed, and some sort of solid contraception for those that are in heterosexual relationships and sexually active has been offered, and all of those checklist has gone through, then they think, oh, well, that's actually not bad. That's how life should be.
Yeah, absolutely. So I love that. So basically you're saying it's important because it interferes, like heavy menstrual bleeding interferes with our quality of life, interferes with relationships, with social situations, with work. They've got to, and again, embarrassment. You're thinking, God, I've got to go to the toilet again. I've just, went half an hour ago. So their productivity, their social life, all of those from the physical aspects of the actual flow. And then the complications with things like iron deficiency as the sort of the next step on, and that then impairing, or causing fatigue, impairing your cognitive function, so your brain function when you're iron deficient. And from our point of view, we see lots of women who weirdly experience cravings related to their iron deficiency. And when you correct their iron deficiency, their cravings go away.
Absolutely. I think it's just a space that causes such a can of worms of negative scenario that we can actually traction quite easily. It is not that hard to replace iron, whether orally or with an intravenous support. But I think even more critical than that, that's very important, but is to actually address why they're bleeding and how we can support that to stop or reduce.
Excellent, which is leading perfectly into my next question, which is what does cause heavy menstrual bleeding?
Okay, so similarly, the numbers here are 50-50, Lucy. So half of the time we go looking, we actually don't find a cause. And it may be, Lucy, that in future there are some fancy sort of hematological things that will be uncovered. But at this present time, roughly 1 in 2 women, we are able to establish a cause or a suggestion that this might be contributing to the picture. And in half of them, we're able to say, look, everything seems normal, but obviously the periods are not normal. And the fact that you are bleeding heavily is not normal. And so we will manage that even though we haven't got an actual cause. And if we break that down further, the causes, Lucy, sort of fit into 2 groups. And this is again FIGO, the organization that's divided them to make it a bit easier for us, clinicians and the community. Basically, one group is structural. So we are obsessing with the uterus itself and asking, are there things that are happening at this level that are contributing to the excessive loss? And then the other aspect is non-structural causes, which are general causes in the body that are now having an impact at the level of the uterus and the amount of bleeding that the woman's having. So if we come back to the first group, there are 4, it's called palm coin, and the palm, basically P stands for polyps. So those little, I call them like little fleshy chandeliers inside the uterus, and they're mostly benign. They're not usually malignant, but some of them can be malignant. So it's really important that we sort of are keeping not only a therapeutic lens to make this person more comfortable and reduce the bleeding, but we're also keeping a diagnostic lens so that we're not missing a precancer or a cancer. Okay. So that's the first cause, polyp. The second cause is fibroids. So fibroids are generally quite common, Lucy, as you know, and they are can be found in more than a quarter of women. And in many women, they will be asymptomatic, but particularly the ones that are relevant for heavy bleeding are the ones that poke into the uterus. If they poke into the uterus, they're then raising the amount of lining that has to be shed. And also the ones that are massive. So sometimes the fibers are really, really big. So they are not only contributing to the bleeding, but then they're also creating pressure symptoms. So you can imagine in the context of a perimenopausal woman who might be waking up from hot flashes, from night sweats, and then also from the bleeding, and then also from the joys of the pressure of the uterus on the bladder. Because remember, the bladder is right in front of the uterus. So if that's really big and massive, it's then going to reduce the capacity of the bladder and increase the number of times a woman needs to go and get up and wee. And so that's our second cause. And our third cause that I mentioned earlier is adenomyosis. Basically, the inside lining of the womb should be exactly there. It should stay in its lane. But sometimes it actually comes outside and it's outside the uterus itself. That's endometriosis. And at other times it's in the wall. So notorious to causing heavy menstrual bleeding is adenomyosis. And that can be a suggestion that we can get through a high quality ultrasound. And the last cause, Lucy, that is related to uterus is cancer. Now, if we put it in context, uterine cancer is not that common. It's 1 in 44 lifetime risk. And for example, I'm comparing it to breast cancer, it's 1 in 7 women. So, however, obviously in women who are bleeding irregularly or abnormally, it is more common in that cohort. So again, if you're having periods that are heavy, it is so important to make sure, rare as it is, that we don't want to miss that person that is having a precancer or a cancer. And then that other whole group of non-structural abnormalities. So they could be, Lucy, something like a tendency to bleed that a woman has. And that might be, like von Willebrand's disease. They might have had a malignancy and being put on a drug called tamoxifen that is for breast cancer treatment. And that increases the lining and makes it more likely. Or, they could have what we call anovulatory cycles. So it could be a hormonal cause, basically. And this is more common in the reproductive age ends, both at adolescents and also in perimenopausal women, where the cycle has become, we have not released an egg, the lining of the uterus continues to thicken and then sheds with a vengeance. So these are some of the commonest causes of heavy bleeding.
Yeah, amazing. And I think, from our point of view, so the cohort of people that we often, or the women that we often work with, as you know, I work with women who are looking to improve their metabolic health. And so they may have overweight or obesity and insulin resistance, type 2 diabetes. And we see, the stories that I hear from them are lots of often heavy periods. They can't wait to get to menopause to finish the periods because they're so awful. And so looking, therefore, I guess, at that metabolic level, increased insulin resistance in particular, it has multiple ways in which it contributes to both the size of the lining, the thickness of the lining. It adds to the risk of fibroids, increases. We know that people who have excessive body weight increase their estrogen, so that increases the lining. There's so many ways in which you can see that it all funnels into the symptom of heavy menstrual bleeding.
I think that's an excellent point, Lucy, you've made, because it's not only the fact that it increases the risk of irregular cycles. We know that women with high BMI have a much higher chance of having irregular cycles, but they are also likely to be heavy. And like you rightly said, it's the unopposed estrogen in the cycles that tends to do that part of the symptomatology. But it's not only that, it's not only the symptoms and the misery of the actual heaviness of the loss and the consequences of that, but it's actually the actual risk that they're carrying. When I spoke about endometrial cancer being 1 in 44, what are our risk factors for that? We know that women with type 2 diabetes, we know that increased BMI because of the excessive estrogen from the adipose tissue that they're exposed to, that then makes the uterus vulnerable, which is not the only cancer that is vulnerable, mind you. Both ovarian, breast cancer is also more likely, but certainly it has a direct effect on the endometrial lining. And so therefore, women who haven't had, they'll cohort that is more at risk is high BMI, type 2 diabetes, not having had a child previously, early start of periods, anything that prolongs our exposure to estrogen, delayed menopause, family history. Occasionally there are women who have a family history of certain uterine type of cancers, and abnormal bleeding. So these are, and of course age, anyone above 50, particularly 45, 50, above that age is slightly more likely. So if we're starting to combine some of these risk factors, we are then more likely to be having a hyperplasia, which is a precancer or a cancer, even though overall numbers are definitely not that high, is what I'm trying to say.
No, I hear what you're saying. And I think it's, I love that. I'm always talking about Goldilocks, the Goldilocks principle of, too much is no good, too little is no good. It's the same with estrogen. You don't want too much estrogen. Too much estrogen causes problems. Too little estrogen causes problems. We want it just right. And, there's lots of things that we can do to adjust that, I guess. So from our point of view, we do lifestyle factors to reduce body fat, to reduce insulin, and try and stabilize some of those hormones. But from a medical point of view, what treatment options do you offer for women?
Yeah, so I think what you're doing, Lucy, is such amazing and phenomenal work, because it is so important to consider that aspect. From a purely bleeding point of view, there are three main groups of support available for women who have this condition. One is medical management, and we do try to start with that with everybody, because it's almost like a pyramid, and we always want to start with the least invasive option if possible. And then this is obviously outside where we're worried about a malignancy or a pre-malignancy. That's a totally different person, where we need to straight away go to a more detailed, probable surgical plan. But medical management, which can include hormones and non-hormones. So we can include, for example, there's a drug called tranexamic acid, which kind of tries to reduce some of the clotting at the level of the uterus. And there's also a drug called non-steroidals, which are like Ponston, which is like mefenamic acid, or like Nurofen, for example. So these are better than, for example, Panadol, where Panadol only tractions pain, but mefenamic acid or Ponston has an ability to reduce inflammation, to reduce pain, but more importantly in this context, to actually reduce some of the bleeding as well. And so I often would prescribe that with tranexamic acid to start with on someone, and also make them aware that the levonorgestrel IUD, which is popularly known as the Mirena, is found to be the most effective medical option for traction of heavy bleeding, and particularly in the cohort of women that you're describing with high BMI, with unopposed estrogen. That is a really good little, almost like I think of it as a little soldier that we're putting in the uterus with them, with permission. And that would then help release a small amount of progesterone. And progesterone is almost like the balancing hormone for heavy bleeding. And it is quite a powerful hormone to try and thin the lining and have the opposite effect of what estrogen is doing. So that's a great option for women. And then, of course, there is the pill, and there are certain injections as well that we can look at. Then if we're looking at surgery, Lucy, there are milder options of surgery or less invasive, which again, we've recently had this heavy menstrual bleeding standard, which is an excellent piece of work that has been updated. And both the previous and the updated version really does get behind use of minimally invasive options first. So these are like day surgical procedures where we burn the lining of the uterus so that that part is removed. It's only suitable for women who have completed or do not desire fertility. And it's quite a good option, Lucy, for women in the perimenopause, because it kind of might be the Band-Aid that would help them get through that period. And then you also have minimally invasive options of like a little magic wand that we can scoop out the fibroid, which is poking inwards, not necessarily a large fibroid. Or we could sort of take out the polyp a bit better and level it out, and then use the ablation. So lots of combinations. And of course, there's a hysterectomy, which is usually reserved for either, if there's a really large uterus and we're having significant pressure effects, if we've used other things and they haven't worked, if there's a certain patient preference, or if there's a fear of malignancy or confirmed malignancy in certain cases, or pre-malignancies. Those are the relative smaller group of women that should have the hysterectomy. And then the last one, Lucy, is radiological options. So you can actually have radiological embolization or management of the heavy menstrual bleeding, that's also a good option for women.
Ah, okay.
So we're kind of spoiled for choice.
Yeah, absolutely. And I think, one of the things that we talk a lot about on at Real Life Medicine is it doesn't have to be this or that. Like, it's not just lifestyle and nothing else. It's not just Ponstan and nothing else. It's looking at all of the options that are available to you and choosing the combination that suits you the best. Obviously, I have a penchant for lifestyle medicine because I can see, so by changing lifestyle and improving our underlying hormonal profile, we therefore either don't need medication or we can use a lower dose. And the lowest effective dose seems to always be the best. Same, a bit like your surgical options, the least invasive.
The lowest tier is the best. It has the least morbidity and the least risk profile.
Absolutely. And then knowing that there are options, more medication or different surgical procedures for those people who have done everything. They've optimized their lifestyle, balanced their hormones, they've tried Ponstan, they've gone the tranexamic, they've had their iron infusion, they're still bleeding. What's next, doctor? Yeah.
I agree, Lucy. And I think the lifestyle side is so important, even post-operatively, even where the bleeding has stopped. That is still such a critical part of patients' journeys that I feel that it's so good to optimize. But like you rightly said, we can use a number of combinations. I think the focus has to be on, am I actually getting to the point where these periods have become tame? Or do I want to do something definitive with the surgical procedure? For example, Lucy, I had someone that said to me, I suffered for a decade for 4 hours worth of my time, one session. And literally wasn't even one session because she was counting from the time she came to hospital, from the day surgical procedure and, the recovery time. And literally time on the table was half an hour.
Yeah,
so,
right. Yes.
Sometimes women suffer so much for something that is so fixable.
Totally. Absolutely. And, every woman is different. Like everything, all options need to be presented because choice, there's power in choice, isn't there?
Exactly, Lucy. And I think that when there are multiple options of care, it is good to be aware of all of them. And then, like I always love it when women give me some philosophy, like some will say, look, I don't want any hormones. Then I'll ask permission that, okay, fine. Would you still be okay if I share some research with you and share some details? So just from an educational interest point of view, and then we will do exactly what you want us to do. So I think it's quite powerful to know all the options that are available and then make an informed choice.
Yes, I love that. I think that, yes, there is definitely knowledge is power, but having the right knowledge is the thing that then gives you that power.
Yeah. And the other thing, Lucy, while we're talking about all different options, is one thing around perimenopausal women that sometimes gets overlooked is their need for contraception for some of them. And what happens is when you are selecting something, keep that as part of your overall checkbox, that what can we optimize with you and for you. Because even though your fertility is declining because we are getting, towards the end of that reproductive age, the actual risk is not zero of having an unplanned pregnancy. So it is important to keep that in mind. And as you know, Lucy, the Australian Menopause Society basically suggests anybody under 50 should have 2 years of contraception support proactively, and anyone above 50 should have at least a year after their final period.
Yeah, absolutely. And I think you're right. There's a lot of chat around that perimenopause period. But obviously women are now being a lot more informed about MHT, or the old name being HRT, and the benefits of that for them potentially. But for women who still need contraception, that it's not suitable necessarily.
Yes, so exactly. So MHT often does not provide contraception, even though it's such a great product in terms of managing hot flashes, in terms of managing night sweats. And in my opinion, one of the best ways to give estrogen is to give it through the skin. But then we kind of need, when we're giving estrogen, we kind of need a product that's going to keep the uterine side from like we've mentioned earlier, from developing excessively. And so in that way, I find the levonorgestrel IUD, the Mirena, actually is a good fit for some women. Obviously, not everyone's going to be happy with everything, but we work with you to try and find, like you rightly said, the Goldilocks point where we're getting the maximum benefit with the least side effects. And so I find, Lucy, that if we have made sure that there isn't any underlying vulnerability, like a precancer or cancer, having Mirena and then having some transdermal estrogen is often a good combination for perimenopausal women, because it helps them from the heavy bleeding point of view. It helps them from a contraception point of view if needed. And it also helps the cohort that is actually going to reach out for some estrogen to partner with that progesterone. So it becomes a vehicle, almost like a cake on which we kind of layer the icing, which is the estrogen.
Yeah, absolutely. I love that. Dr. Talat, this has been brilliant. Such a good conversation. So good to talk about periods. It doesn't have to be secret women's business. We're allowed to say the word tampon out loud. It's really, really helpful just to start normalizing it. It's not secret women's business that we have to walk around everything in a brown paper bag. So thank you for all the work that you're doing. If people want to connect with you, how do they find you?
So we've started Australia's first abnormal uterine bleeding hub, so which basically means that we're trying to run a number of services under one roof and say, look, walk through our doors, whether they're virtual or actual, and we will then sort of assess you. We will, including an ultrasound, and we will then do the necessary workup to try and figure out why this is happening. We can replace iron if needed. And if needed, after all that, like we mentioned, menopause management or adolescent health or whatever is required from the perspective of the person at the set. It's very individualized care. And we're based in French's Forest in Sydney, but we do a lot of virtual workup as well. And so it's a team of women that includes a team of clinicians that includes a GP, a physio, for example, social worker. We have advanced endometriosis surgeon, and it's quite a big cohort of doctors that look after women with heavy bleeding. And so we would love to hear from you. If you type Women's Health Road, and if Lucy, you'll be kind enough to share our link.
Yeah, the link will be in the show notes. Absolutely.
Thank you. An abnormal uterine bleeding hub.
Yeah, absolutely. And I think this is it, ladies. It's gone are the days where we just soldier on and, I think, it'll be better next period. Heavy menstrual bleeding is a serious medical issue. It's, often symptomatic of something underlying. As you said, 50% of women will have something underlying that's causing it. And so it's time to look at it seriously and seek help for it. And as I said, I'll put the link for Dr. Talat's services in the show notes.
Thank you, Lucy.
You're welcome.
Thank you so much. I think it's so important to basically have the quality of life that you deserve.
Totally.
You know what I mean? Like, we really shouldn't be suffering from any quality of life issue that we can help you fix.
Absolutely. I love it. All right. Thank you very much.
Thank you very, very much.
Beautiful peeps. Have a gorgeous week. And I will be back next week with another expert in our menopause series. Bye for now. The information shared on the Real Health and Weight Loss podcast, including show notes and links, provides general information only. It is not a substitute, nor is it intended to provide individualized medical advice, diagnosis, or treatment, nor can it be construed as such. Please consult your doctor for any medical concerns.